You've probably heard of CBT-i, or cognitive behavioral therapy for insomnia, as the first-line treatment for insomnia. But what exactly is it, and which components of CBT-i are shown to be the most effective? At the end of this training, you'll be able to explain this to your patients in your practice. I'd like to invite you to get my free melatonin brand guide for physicians and health practitioners. Many of our patients are taking melatonin. It's the fourth most popular natural product taken by adults in the US, the second most popular natural product taken by kids in the US, yet melatonin quality is of great concern, as outlined recently in studies in JAMA in the Journal of Clinical Sleep Medicine. So as physicians and health practitioners, we need to know how to guide our patients on good quality supplements. So you can get my free brand guide at intrabalance.com/melatonin. I go into the third-party tested melatonin supplements, the different formulations and brands that are available. So you can go ahead and grab that. If we haven't met before, I'm Dr. Nishi Bhopal. I'm a physician. I specialize in integrative psychiatry and sleep medicine. This channel is for you, the health practitioner who wants to learn more about sleep. And a quick disclaimer, the information I'm presenting is information only and is not medical advice. Okay, so let's talk a little bit about CBT-i and what it is, what it entails, so that you can better explain it to your patients. This graphic is based on a 2024 study that was in JAMA Psychiatry. You can see the reference down there. You can go ahead and pause this video and look up that reference if you want to take a deeper dive into the study. In this systematic review, they were looking to see what components of CBT-i are the most effective and if you can actually parse those out. Now, there were some limitations to that study, including differences in delivery of these different components of CBT-i. Oftentimes, these components are delivered in conjunction with one another, so it can be hard to parse out exactly what the treatment effect is of these different components. And there was a high dropout rate in many of these studies that they looked at as well. But they did find some interesting things, which are highlighted in this diagram. First of all, let's just get oriented to what CBT-i is. It's the first-line therapy recommended by the American Academy of Sleep Medicine, the AASM, and the NIH consensus for adults with chronic insomnia disorder. What that means is that it's the first thing that we should be recommending to patients who are struggling with chronic insomnia before going to medications, before going to supplements and other things. CBT-i has a really high success rate. Now, I know it's challenging for a few reasons. One, it's hard to find a CBT-i provider. There are very few sleep specialists available. And number two, it can be hard to motivate your patients to engage in the CBT-i protocol. So we're going to talk a little bit about that today and how you can actually get your patients to do CBT-i and resources to send them to. Okay, so let's look at the components of CBT-i. And I like this diagram because it was broken down into treatments that were beneficial, not so beneficial, and then potentially harmful. Let's start in this potentially harmful section. You may be surprised to see that relaxation procedures is in that potential harmful category. And I'm going to come back to that and explain why that is in a moment. Waiting for treatment is also in the potentially harmful category as well. And that's not really surprising, right? If someone's not yet in treatment, they're waiting for treatment, they're not getting better, so it's potentially harmful, but they also may be engaging in the perpetuating factors that contribute to ongoing chronic insomnia. And you may remember back to the 3P model of chronic insomnia, the predisposing factors, the precipitating factors, and the perpetuating factors. CBT-i focuses on those perpetuating factors that keep the person in this vicious cycle of insomnia, and these include things that are often harmful. So they may be turning to external sleep aids, they may be spending more time in bed hoping they're going to get more sleep, they may start having unhelpful thoughts that keep them in a state of hyperarousal, they may become preoccupied with sleep and insomnia, and so it becomes the focus of their life, and the harder they try, the harder it is to sleep. Those are examples of some of the perpetuating factors. Like I said, we'll come back to the relaxation procedures in a moment, and I'll explain why those might be potentially harmful, but let's go into the not so beneficial category here. Here we have automated encouragement. This is referring to automated reminders that will go out to patients saying, hey, keep going with the insomnia protocol. It's not necessarily referring to support that they may be getting in between sessions, but just the encouragement to keep going with treatment may not be all that beneficial. Sleep hygiene education is also in the not so beneficial category. This is not surprising. We know that sleep hygiene alone is not sufficient to treat chronic insomnia. Sleep hygiene is like dental hygiene. Dental hygiene is a way to keep your teeth and gums healthy, but if there's a dental problem, dental hygiene alone is not going to be able to fix it. That's when you need to work with a dentist to figure out the right treatment plan. Sleep is like this. When patients are struggling with chronic insomnia, sleep hygiene education is not enough to help them. They need a specific treatment plan that's going to address those factors that keep them in that cycle of chronic insomnia. And sleep hygiene alone is not enough for that. Sleep hygiene is one component of CBT-i. It is not what CBT-i is. This is an important aspect of psychoeducation for your patients. Many times patients conflate CBT-i with sleep hygiene. I've seen this with practitioners as well. Some practitioners equate CBT-i with sleep hygiene education. And of course, I know you're not doing that because you know know the difference between CBT-i, which includes all of these different components, and sleep hygiene education, which is one small piece of it, but it's not enough. Let's look at some of the components of CBT-i that are shown to be beneficial. We'll start over here. Cognitive restructuring is one of them. This is shifting thoughts from unhelpful thoughts that might keep patients in that state of hyperarousal, like, oh my God, I had another sleepless night. I'm so sick of this. Why can't I just get sleep? I'm not going to be able to get 8 hours of sleep, and without that, I can't function. I cannot sleep without sleeping pills. I need those to help me sleep. So that's an area of opportunity to work on restructuring those thoughts that keep them in the cycle of insomnia. The next component that's shown to be beneficial is sleep restriction, which is not a term that I love because it implies that we're restricting how much sleep a person is getting. And when someone with insomnia hears this term sleep restriction, it's a bit anxiety provoking to them because they're thinking, wait, I'm already not getting enough sleep. Why do I want to restrict it even more? Sleep restriction is actually time in bed restriction. It's not about restricting sleep. It's restricting the amount of time the person is spending in bed. Another way to talk about it is sleep efficiency training, because the goal with sleep restriction or time in bed restriction is to increase the person's sleep efficiency. The next component here is stimulus control. This is where we want to reduce that conditioned arousal that happens when people are in bed. When people struggle with insomnia, they usually spend more time in bed hoping they're going to get more sleep, so that reduces their sleep efficiency because they're in bed for long periods of time while they're awake. And now they're conditioned to associate the bed with being awake and being anxious or frustrated. Stimulus control is about eliminating that association so that eventually the bed will be associated with sleep and not with being awake and being frustrated. This is why teaching the patient relaxation procedures alone can be harmful, because what might happen here is the patient might now try doing these relaxation procedures, whether it's a guided meditation or breathing practice or some other form of relaxation, with the intention that it's going to help them sleep. Now they've developed an attachment to that outcome, that if I do this relaxation, it's going to help me sleep. And then what happens? They don't fall asleep. So now they have more anxiety, they have more frustration, they spend more time in bed trying to lie very still. Okay, let me do my breathing, let me listen to my meditation. Wait, why aren't I asleep yet? So it actually is counter to the stimulus control and the sleep restriction recommendations, and it can also lead to some of those unhelpful thoughts that perpetuate the hyperarousal. This is not to say that relaxation procedures aren't helpful. They are very helpful, but they need to be done in conjunction with a whole CBT-i protocol and not done on their own. So sending your patient away with a meditation practice or a handout on progressive muscle relaxation, it may not be all that helpful, and it can be potentially harmful. Now, these third wave components refers to aspects of mindfulness and ACT, or acceptance and commitment therapy, which are shown to be beneficial for people struggling with insomnia. And then in-person delivery is mentioned here. In-person delivery is very effective for CBT-i. Studies show that virtual delivery or digital delivery of CBT-i is effective as well. That leads us into resources. I'm not going to go into detail into how to implement CBT-i. There's other videos on this channel about that, and if you want more information on implementation of CBT-i, just let me know in the comments if there's specific questions that you have about it, and we can look at that. But I wanted to share some resources because I hear from my colleagues all the time that they either can't find a CBT-i practitioner or they're referring their patients for CBT-i and they're just not following through. So let's address those two things. The first is, how do you find a CBT-i practitioner? Well, now with the online world, with telehealth, it's much more accessible than it was before. It can be done in person, so you may have local clinics that are offering CBT-i or local psychologists or other sleep specialists that are able to offer it in person, or you can do it via telehealth or via an app. I have another video on a variety of different resources that are available for CBT-i, so you can check that out as well. But I'll just share a couple of things that can be helpful. One is the Society of Behavioral Sleep Medicine website. They have a database where you can search for practitioners all around the world. You can go to their website and look for a practitioner in your area who is trained in behavioral sleep medicine. There's also a whole world now of sleep coaches that are available. You can see my video with Morgan Adams. She's a sleep coach talking about how patients can work with a sleep coach to overcome insomnia. I'm really excited to announce this because I have not shared this on this channel yet, that we are now offering CBT-i coaching in my practice. Our coaching service is available to patients in all 50 states, not just in California where my practice is based, because our coach is able to see patients outside of the state as well. And we incorporate CBT-i with these third wave components that are shown to be beneficial. If you're seeing patients who are struggling with insomnia, circadian rhythm issues, or other sleep issues, my practice is now available to help you no matter what state the patient is located in. There are so few CBT-i practitioners available, so it's wonderful to be able to offer this at a bigger scale. Now let me address the other question where it's hard to get my patients to engage in CBT-i. Well, the first thing is that many patients are not aware of what CBT-i even is or what it entails, or they may have heard horror stories from other people on the internet or people that they know about sleep restriction. That's usually the scariest part of CBT-i for people with insomnia. So here's what I tell patients. One is, look, this is the first-line gold standard treatment for insomnia. It's really effective. It does take work. If you're willing to put in the energy and the effort required, you will be able to overcome insomnia. Insomnia issues are highly treatable. I'll talk to them about the perpetuating factors that feed into the cycle of insomnia. Validate their frustration. Look, I know you know about sleep hygiene. People with insomnia usually have better sleep hygiene than anyone else. They often have rigid bedtime routines. They can tell you all the sleep hygiene recommendations. They've tried many medications. They've tried all the supplements. They've tried the gadgets. But often what they haven't done is really worked on the cognitive restructuring, the sleep restriction, the third wave components, the mindfulness, the ACT therapies, the stimulus control, all of these things that are shown to be beneficial. The other thing I'll emphasize to patients is that CBT-i is a really personalized protocol. There may be a high dropout rate because sometimes it's done in a very rigid way that is kind of off-putting to people. Working with a practitioner or within a program that allows for some tailoring and personalization to that person's needs. And I love the ACT framework because it's really connecting this treatment to their personal values. Doing it in that way can feel much more palatable to people and can be much more effective because you're really collaborating with the patient. I would also encourage them to consider what type of delivery system might be better for them. Do they prefer one-on-one in person? Do they prefer doing it in a group setting? And that can be really helpful for some people to see others who have had success and to learn from them and to go through it with a cohort of people who understand what you're experiencing. That can be helpful for people. But others prefer the privacy of one-on-one. They might prefer using an app or using a digital format that comes with a sleep coach. There are these different aspects available nowadays as well. So there's lots of different options available. If you have patients who can benefit from CBT-i with those third wave components I was talking about, we're now accepting referrals for sleep coaching at pacificintegrativepsych.com. If you are a referring practitioner, you can send us an email. Our email address is on the website. Or if you are a client who's interested in these services, you can schedule a free consultation via the button on the website, and that's with our intake coordinator, and they'll go over your needs and make sure that our services are the right fit for you. If information like this is helpful for you, go ahead and subscribe to this channel and let me know in the comments what questions do you have about clinical sleep medicine.